Good day, future RMTs. Once again, welcome to our online classroom. And in today's lecture, what we are going to discuss is all about renal diseases. To start with, let's have first our learning outcomes. Our learning outcomes are as follows. Number one, 7.1 is to differentiate among renal diseases of glomerular, tubular, interstitial, and vascular origin. Describe the characteristic clinical symptoms, etiology, and urinalysis findings of renal diseases, and of course, to interpret the laboratory results associated with renal diseases. Alright, so let's have our discussion. Now, as we all know, our kidney is an important organ. Our kidney plays an important role not only in filtering our blood, but also in the excretion of our metabolic waste product. If you still remember in our first discussion, we said that urine is a very important body fluid because that is one of the body fluids that can be used to identify, to diagnose the condition of our patient. Okay? Remember guys that in renal function or our kidney, okay, um, yeah, our one of the function of the kidney is to filter our blood. That's why urine is a very useful fluid to assess not only, okay, I want to make it clear, not only the problem in the kidney, but also the other problem in the body. That's why a routine analysis includes urine analysis. Routine examination includes urinalysis. Okay? Considering that the major function of our kidney is to filter blood, then it is evident that uh, damages or potential damages or substances caused by potential damages can be found in our urine. Now, our renal disorder is classified into glomerular, tubular, interstitial, or based on the area of the kidney primarily affected. Now, in order for us to remember and to take note this function, no, this topic, it is important to us to remember what is the function of our kidney. Okay? And in order for us to diagnose the condition, identify the condition, then it is important to remember the functions of the kidney as well as to indicate what are the abnormalities in the urine analysis. And of course, we should be able to correlate the results that we have. Okay, so this is the classification again of renal diseases. We have the glomerular, tubular, or interstitial. Now, the first thing that we are going to discuss today is on about glomerular diseases or glomerular disorder. Okay, from the word itself, glomerular meaning to say the problem is within the glomerulus. Okay? Now, remember people that most of the glomerular disorders are usually the origin of it is because of immunologic disorders. Excuse me. Okay? It's because of the responses in the immune complexes caused by immunologic disorders, which causes damage to our glomerulus. Example of immune complexes that can damage our glomerulus includes immunologic reactions, increase in serum immunoglobulin, that's why we have IgA nephropathy, okay? Complement of the immune system, and the complements of the immune system includes the complement, no? The neutrophils, lymphocytes, monocytes, cytokines, okay? These are the cellular infiltrations or proliferations, which means, okay, which means if there are cellular infiltrations or proliferations, it will yield into the thickening of the glomerular basement membrane. Thickening of the glomerular basement membrane can cause damage in the function of our glomerulus. And remember guys, the complement-mediated damage to the capillaries and basement membrane. Now, the question is, what is this complement is all about? And take note guys, that this complement is capable to cause damage, produce damage or changes in the membrane of our glomerulus. Now, however, there are non-immunological causes of glomerular diseases. Okay, in other words, yung glomerular disorders can be classified, or the etiology of that can be classified as A, based on the immunologic responses, B, based on non-immunologic causes. Now, when we said non-immunologic rather, thank you, non-immunologic causes, it is due to exposure to chemical toxins or chemicals or toxins, which includes drugs, deposition of amyloid materials from synthetic disorders, okay, and basement membrane thickening. The other one is because of the responses into complement, because of, let's say, for example, you have a bacterial infection, the production of the complement to suppress the multiplication of bacteria or microorganism causes damage in our kidney. Thus, it will give us a thickening in or damage into our basement membrane. Now, you might ask, what is this deposition of amyloid? It is amyloids. Okay. Remember, guys, that amyloids, should I write? I guess I need to write. Okay. When we said amyloids, okay, let me just choose the ink that I want. Okay, so there you have it. When we said amyloids, what does it mean, sir? Si amin na lodi mo? No. When we said amyloids, these are aggregates, okay, of proteins. Oh, that's why it can cause damage in the glomerulus, no? Aggregates of proteins that become what? Folded in shape that allows many copies of that protein to stick together, forming fibrils. This is why there is a problem if there is a deposition of what we call amyloids, because they're aggregates of protein. And once that these proteins not stick together, then it will cause damage to our kidneys. Okay? So remember guys that glomerular disorder, the etiology might be coming from the problem, no? And the immunologic responses, or due to non-immunologic disorders. Okay? Now, when we said glomerulonephritis, what does it mean? Okay? When we said glomerulonephritis, it is associated in the inflammation processes. Inflammation process within the glomerulus. No? The term glomerulonephritis refers to a sterile inflammatory process, okay, that affects our glomerulus. Okay? Now, glomerulonephritis is associated with these three findings: blood, protein, and cast. Kaya, why is it glomerulonephritis is associated with blood, protein, and cast? As we all know, no, as we all know, the major function, no, the major function of our glomerulus is to filter blood. Now, if there is a damage, if there is an inflammation, the reason why that there is an inflammation is because there is a damage. Since there is a damage in our glomerulus, then its function will be impaired. Having said that the function is impaired, then proteins, particularly albumin, will be able to pass in our glomerulus. Bakit? Kasi nasira na yung basement membrane. There's a problem in the basement membrane, which affects the shield of negativity. I hope you can still follow. Okay? And since along with the process, along with the damage, since there is a damage, may sira, may sugat, there is bleeding. And if there is bleeding, then it is associated in what we call blood in urine. Or this is what we refer as hematuria. Okay? And since there's an increase in proteins, then it is possible that there will be a presence of what we call cast. As we know, cast originates in our kidney. Okay? Cast originates in our kidney. Again, what is the matrix of protein? Correct. The Tom Horsfall protein. Glomerulonephritis may progress from one to each other. Ano ibig sabihin? It means that it can worsen. It can cause renal failure. From a simple damage in the glomerulus, from a simple damage in our filtering capability, then it can lead into a nephrotic syndrome. Nephrotic syndrome is a broad term that affects the whole nephrons itself. And since that is the functional unit of our kidney, it can lead in what we call renal failure. The question is, sir, can I still survive if I develop renal failure? Well, I don't want to discourage you. I don't want to discourage everyone who is having their problem within the kidney, with their kidney. No? If you have a family friend or a family relative who who have this kind of disease, I don't want to discourage you, but mind you people, the only medication that can help the patient with renal problem is kidney transplant. Sir, no, because sir, dialysis could help. Yeah, from the word itself, could help, but it doesn't mean it will heal the problem within the kidney. Okay? Because we cannot give drugs. We cannot give uh, medications. Why? Drugs is a toxin. Drugs is a chemical. And as we all know, as we define glomerulonephritis, one of the etiology of that is non-immunologic responses or non-immunologic. And one of the examples under non-immunologic is exposure to toxins. Okay? A simple urinary tract infection that becomes upper urinary tract infection can also lead into these processes. So as we go along, we will discuss those things. All right. So let's have first acute post-streptococcal glomerulonephritis. Okay? So let's have first acute post-streptococcal glomerulonephritis. Now, from the word itself, acute, from the word itself, post-streptococcal. What does it mean? Pag po sinabi nating post-streptococcal or after exposure to the toxin produced by our streptococcus. Particularly what? Streptococcus pyogenes. Well, sir, if I still remember my lecture or our lecture in Streptococcus pyogenes, Streptococcus pyogenes is a gram-positive cocci in chain. So that is what we have here in our illustration. Okay, that is a gram-positive cocci in chain, and usually Streptococcus pyogenes is a microorganism that causes what you call this? That causes fever-producing bacteria. Okay, and As we all know, sir, Streptococcus pyogenes is a flesh-eating bacteria which invades the deeper tissues and organs. Okay, so I will write so that you will remember, no? Even though this is not our bacteriology class. Now, remember guys, Streptococcus pyogenes okay, this is a gram-positive cocci in chain. Kaya nga strep right? Gram-positive cocci in chain. This is a fever-producing bacteria, no? Can cause fever, or also known as the fever-producing bacteria. Take note, guys, that this is also capable of what we call flesh, no? Flesh-eating bacteria, also known as the flesh-eating bacteria, which invades the deeper tissues. Okay? And take note, guys, that Streptococcus pyogenes is also associated in what we call rheumatic fever. Okay, what do we mean by rheumatic fever? When we said rheumatic fever, this is a inflammation of or rheumatic heart disease. Now, this is the inflammation of heart. Inflammation of the heart, okay, joints, and blood vessels, okay, because of what? Because of the complication, saan? Complication of pharyngitis. How do you spell that? Yeah. I remember. Pharyngitis. Okay? I'm sorry, you can see it na pala. Yan. Complication of pharyngitis. In other words, remember guys that your Streptococcus pyogenes, C, is primarily a bacteria of the respiratory tract. No? Streptococcus pyogenes is a microorganism that causes respiratory problems or respiratory disorder. Oh, sir, that is a respiratory disorder. But how come that this microorganism causes glomerulonephritis? Now, from the word itself, as we define from the word itself, the disease itself, post-streptococcal glomerulonephritis, which means there is a exposure on the chemical toxin, particularly on the M protein on the cell wall of our Streptococcus pyogenes that causes immune responses, immune complexes that deposits on our glomerulus, which causes damage. No? However, remember guys that AGN or acute post-streptococcal glomerulonephritis is a manageable naman. Okay? That is a manageable disease. Okay? Ibig sabihin, kaya pa siyang gamutin. Now, what are the symptoms associated in post-streptococcal glomerulonephritis? It includes fever, edema. No? Edema is accumulation of the fluid within the tissue. No, edema around the eyes, fatigue, okay, hypertension, okay, oliguria, and hematuria. Now, the question is, why there is oliguria? Oliguria means there is a decrease on the volume of the urine or on the urine output. Why there is a oliguria? It is because of the deposition of immune complexes in the kidney, okay, in the glomerulus. Okay? Now, another thing to remember about post-streptococcal glomerulonephritis is what happened during the course of infection. Now remember guys No, the nephrogenic strains of Streptococcus pyogenes or the ano ba? Nephrogenic, nephrogenic, I'm sorry. The nephrogenic strains of streptococci form immune complexes in the circulation, okay, with their corresponding antibodies deposited on the glomerular membrane. So that is the problem. Why someone develop post-streptococcal glomerulonephritis. So ibig sabihin, sir, if I have a pharyngitis and the cause of the pharyngitis that I have is because of glomerulonephritis, then it means that there is a chance that I might develop acute post-streptococcal glomerulonephritis. Yes. Okay? And the inflammatory reaction took place after, no, I'm sorry, the inflammatory reaction affects the function of our glomerulus. Okay? Now remember that it is manageable, no? Successful management of the secondary complication includes hypertension and electrolyte balance until the immune complexes is totally removed in the glomerulus, have been cleared in the glomerulus. Okay? Now, if this permanent, or if, I'm sorry, if this temporary deposition of our immune complexes was removed already, it will not cause permanent damage in the kidney. That's what I've said, no? Post-streptococcal glomerulonephritis is manageable. Now, I want you to remember the primary urinalysis results of a patient with post-streptococcal glomerulonephritis, which includes marked hematuria. Ibig sabihin, mataas ang presence of blood in the urine. Proteinuria, since there is a deposition of immune complexes, glomerulus fails to filter the urine, the blood. Oliguria, because of the deposition of immune complexes which blocks the release of the glomerular filtrate. RBC cast, because of increase in the presence of blood. Dysmorphic RBC because of the damage in the kidney. Hyaline and glomerular cast, as well as WBC cast. Okay? So please remember this 7 primary urinalysis results associated with post-streptococcal glomerulonephritis. Next is we have subsidies of subsides toxicity. Now, kapag po nag-okay na ang ating urinalysis, there is still the urine appears normal upon macroscopic examination, but there is a still microscopic hematuria. In other words, no, may presence pa rin ng RBC. Mataas pa rin yung presence ng RBC, but not the same as what is on the primary stage of glomerulonephritis. In other words, it subsides. Nag-o-okay na yung ating glomerulus, yung function ng glomerulus. Now, the other laboratory tests that can be done in cases of acute post-streptococcal glomerulonephritis is we have blood urea nitrogen. Okay, remember guys that BUN is elevated in acute stages of AGN or acute glomerulonephritis. Or you can also perform a enzymatic reactions or ELISA or a rapid test, which is your anti-group A streptococcal enzyme. Why anti-A streptococcal enzyme? Because Streptococcus pyogenes belongs to group A of Streptococcus. Remember, group A Streptococcus, ano po yung protein on the cell wall? M. protein. The next line is we have the rapidly progressive glomerulonephritis. Okay? Remember guys that when we said rapidly progressive glomerulonephritis, this is a more serious condition as compared to acute post-streptococcal glomerulonephritis. Okay? Why? Why is it considered a more serious? Because it has a poor prognosis. No? A poor prognosis, ibig sabihin, wala ka masyadong nararamdaman. Walang masyadong nakikitang signs and symptoms. However, it can be leading or it can lead to a renal failure. Okay? Now remember guys that this rapid progressive glomerulonephritis, also known as the crescentic, no? The symptoms are initiated by the deposition of immune complexes. So almost the same thing with our post-streptococcal glomerulonephritis. Okay? Now, the complications includes another form of glomerulonephritis. That's why it can lead into a renal failure. That's what we mean, no? Often terminating into renal disease because why? It can lead into other form of glomerulonephritis. Now, immune systemic disorder is one of the conditions why someone develop rapidly progressive glomerulonephritis. Best example of that is SLE, or also known as the systemic lupus erythematosus. Again, I repeat, that is our systemic lupus erythematosus, which is a systemic immune disorder, and this is a damage in which body's immune system mistakenly attacks healthy tissue. How poor you are, no? You have this condition and your immune system attacks, instead of foreign substances, attacks the normal tissues. Hey, now, rapid progressive glomerulonephritis causes permanent damage to the capillary tuft. Okay? And permanent damage to the capillary tuft may produce centric formations containing macrophages. That's why we call it as crescentic glomerulonephritis. Okay? It can also cause damage to the macrophages to the capillary walls, which is the reason why it can progress into chronic glomerulonephritis, or worst case scenario, it can lead into what we call renal failure. Okay? Now, I want you to remember the laboratory results associated. Ito na pala. I want you to remember the laboratory results associated with rapid progressive centric glomerulonephritis. Of course, there will be an elevated protein levels. That is true with our renal failure. Very low glomerular filtration rate, increased fibrin degradation products and cyroglobulins, and we have depositions of immunoglobulin A immune complexes in the glomerulus. Okay. Remember guys, there is a deposition of immune complexes in the glomerulus. Next in line is we have good pasture syndrome. Okay. In good pasture syndrome, there is a morphologic changes to the glomeruli, resembling those in the rapid progressive glomerulonephritis. Okay? However, a good pasture is a cytotoxic autoantibody appearing, no, to form, or there's an attachment of what we call cytotoxic antibody formed during viral infections. A while ago, in post-streptococcal glomerulonephritis, there is a deposition of immune complexes because of bacterial infection. In good posture syndrome, there is a deposition of immune complexes because of the cytotoxic antibody because of viral infections. Now the question is, what do we mean by cytotoxic antibodies? When we said cytotoxic antibodies, these are valuable prognostic factor. I repeat, these are all valuable prognostic factor for long-term kidney allograft survival. I repeat, this is a long-term kidney, long-term prognostic or a valuable prognostic factor for a long-term kidney allograft survival. Okay. Bakit po nagkameron ng viral infection? Because of the virus. What a question, sir. Okay. This viral infection damaged not only the respiratory system, but also the glomerulus. So, meaning to say, the major site of the infection is the respiratory system as we define because of the deposition of viral respiratory infections or viral infections or viral viruses. Respiratory viruses rather. These respiratory viruses definitely causes damage in the respiratory tract infection, and the cytotoxic antibody develops damage in the glomerulus. Now, if we are going to discuss or if we are going to have here a good posture syndrome, now in relation to viral infection causes respiratory signs and symptoms, which includes hemoptysis, the production of blood with sputum rather, the production of sputum with blood streak, and dyspnea. Dyspnea is a medical term for difficulty in breathing. Now, like what I've said, good posture can lead into a chronic glomerulonephritis, or worst case scenario is end-stage renal disease or ESRD. Now remember guys, ESRD. Now how about sir, the laboratory findings for good posture? It includes macroscopic hematuria, not only microscopic. Oh, well, of course, microscopic is included, but there is also macroscopic hematuria. Meaning to say, there is a observable number of blood in the urine, which causes red color urine. Well, of course, proteinuria is present. Now, remember, guys, proteinuria is always present. And there is a presence of what we call RBC cast, and of course, anti-glomerular basement membrane antibody. Remember, there is a presence of what we call anti-glomerular basement membrane antibody. Now the question is, how does this anti-glomerular basement membrane is seen or observed in a patient with good posture syndrome? Okay. Remember guys that there is an attachment of what we call autoantibodies to the basement membrane, followed by complement activation that produces our anti-glomerular basement membrane. Okay? And remember that this anti-glomerular basement membrane is not detected in the urine, but rather detected in the serum. Okay? Next is we have here Wegener's granulomatosis. I'm sorry. We have here Wegener's granulomatosis. So ano naman po yung meron sa Wegener's granulomatosis? Okay? This causes granuloma That's why we call it granulomatosis. There is what we call granuloma. What does it mean? When we said granuloma, that is a mass of the tissue that is typically produced in response to infection, inflammation, or the presence of foreign substances. I repeat, when we said granuloma, that is a mass of the tissue that is typically produced in response to infection, inflammation, or the presence of foreign substances. Okay? Remember guys that Wegener's granulomatosis is a granuloma producing in the inflammation of the small blood vessels. Okay? The key to the diagnosis of Wegener's granulomatosis is the demonstration of this ANCA. This ANCA binds to the neutrophils in the vascular walls that produces damage to the small vessels in the lungs and as well in the glomerulus. Okay, now what is this ANCA? When we said ANCA, that is anti-neutrophilic cytoplasm autoantibodies. Again, when we said ANCA, that is anti-neutrophilic cytoplasm antibodies. Okay, so after producing or after this ANCA binds with our vascular walls, it can lead to damage in the lungs, small vessels of the lungs, and as well as in the glomerulus. Okay, this granuloma produces inflammation to the blood vessels. Now, for pulmonary symptoms, since this is capable of causing blood vessel damage, now for pulmonary symptoms, it includes hemoptysis. Again, when we said hemoptysis, the presence of blood in the sputum, no, and then it will develop into renal involvement that will be possibly progress into end-stage renal disease. For Wegener's granulomatosis, urinalysis results includes microscopic and macroscopic hematuria, proteinuria, RBC cast, and of course, elevated serum creatinine as well as BUN. Remember guys that creatinine and BUN is a good indicator or not a good parameter in order to assess our kidney function. Now, there are other tests, no, other significant tests for Wegener's glomerulonephritis. We have here testing for ANCA. Again, when we said ANCA, that is anti-neutrophilic cytomembrane, okay? And the test for ANCA includes the following. We have to incubate the patient's serum with either ethanol or formalin. Okay? The purpose of that is for preservation. And then examine the preparation using indirect immunofixation, a immunological test, to detect serum antibodies attached to the neutrophils. If you use ethanol, we have P-ANCA. If you use formalin, we have C-ANCA. When we said P, P stands for perinuclear, anti-neutrophilic, okay? Anti-neutrophilic cytoplasm and autoantibodies. When we said C-ANCA, it means cytoplasm. Okay? So remember guys that there is other significant tests, aside from urinalysis, to develop or to assess if you have Wegener's granulomatosis, and that is what we call testing for the ANCA. Alright. Next is we have here a Henoch-Schönlein purpura. Okay? We have Henoch-Schönlein purpura. There are some references or some dictions or pronunciations for this one. Henoch-Schönlein. Some doctors pronounce it as Henoch-Schönlein purpura. No? It's up to you how you will pronounce this one. At the end of the day, the best thing to remember is how you will spell it correct. No? Henoch-Schönlein purpura. You know guys that Henoch-Schönlein purpura is a problem not only in the kidney, but also a problem within the platelet disorder. Now, this is a vascular problem that can cause a problem in the kidney. Okay, so when we said henosyolin purpura, the predominant characteristic of this one is the membranous glomerulonephritis produce a petechiae. No, uh, when we said petechiae, that is a problem. No, meron pong mga uh, spots in the skin, and that is because of the problem in the platelet. Okay. Now, it occurs primarily in the children, most especially after viral respiratory infections. Okay? And there's a decreased platelets, disrupts vascular integrity. That's why there is a petechiae, may mga bruises, no? And that is what we call purpura. The initial symptoms of henosyolin purpura include hemoptysis and melena. When we said melena, this is not the wife of President sino ang president ng USA? Yeah, kung sino man, Trump, no, hindi siya yun. When we said melena, that is blood in the stool which causes a black color of the stool. Now, remember guys that the glomerulonephritis produced, that in this problem, the first problem is about the viral infection, about the virus. Okay? Hindi naman yung mismong kidney agad. Now, the problem why you develop a problem in the kidney is because of the deposition of the immune complexes caused by this viral infection. Okay? Now, in terms of renal involvement, the most serious complication includes hematuria, heavy proteinuria, and the presence of RBC cast. We can also use FOBT. What do we mean by FOBT? When we said FOBT, it is our fecal occult blood test. When we said occult blood, yun yung mga blood which is not seen in a routine microscopic examination. In other words, they are what we call the hidden RBC. Okay. Remember guys that in henosyolin purpura, okay, the recovery with normal renal function is seen with more than 50% of the patient, while the other progresses into other form of glomerulonephritis or eventually into a renal failure. In other words, you can survive. You can, there is a remission, but 50% of the cases of a patient with henosyolin purpura may develop into what we call other forms of glomerulonephritis, or worst case scenario, lead into what we call renal failure. Now, when we said membranous glomerulonephritis, the problem on this one is there is a thickening on the glomerular basement membrane because of the deposition of IgG. Kanina, deposition of IgA associated with rapidly progressive glomerulonephritis. In membranous glomerulonephritis, there is a thickening of what we call glomerular basement membrane. It is because of IgG deposition. Okay, membranous glomerulonephritis is associated with systemic disorders. Systemic disorders includes SLE, which is your systemic lupus erythematosus, and SLE is associated with rapidly progressive glomerulonephritis. SLE is also associated with membranous glomerulonephritis. Kay rapidly progressive glomerulonephritis, you have deposition of IgA. Kay membranous glomerulonephritis, you have the deposition of IgG. Okay. There are a lot of systemic disorders that is associated with membranous glomerulonephritis, which includes again the SLE, we have the Sjogren's. That is how we pronounce that. Hindi po Sjogren's. We pronounce it as show, as in show, palabas, greens, Grin. We have Sjogren's syndrome, secondary syphilis, hepatitis B, gold and mercury treatments, as well as malignancy. Now, what is Sjogren's syndrome? When we said Sjogren's syndrome, this is a disorder of our immune system, okay, that is identified by two most common symptoms. Number one, dry eyes, and number two, dry mouth. Okay? Sjogren's is a systemic disorder or a disorder of our immune system, and there is two most common symptoms of that, which includes dry eyes and dry lips. Now remember guys that membranous glomerulonephritis, okay, may develop slowly progression to nephrotic syndrome or possible remission. Na ibig sabihin, pwede po siyang mag-develop into nephrotic syndrome, worst problem, or there is a possibility of remission, which means you can survive. Okay? Remember also that membranous glomerulonephritis has the possibility to progress into what we call thrombosis. When we said thrombosis, that is a blood clot inside the blood vessels. Remember guys, when we said thrombosis, that is a blood clot within blood vessels. Now, how about the laboratory findings? Laboratory findings of membranous glomerulonephritis includes microscopic hematuria, elevated serum protein, urine protein rather, and the other significant test includes anti-nuclear antibody. Why anti-nuclear antibody? Because of the because of the immune complexes, okay? Because of the immune complexes associated with other diseases, okay? Or we can also use hepatitis B surface antigen, HBsAg, because it is associated in viral hepatitis. We said that, no? Particularly the hepatitis B. And it is also associated, or we can also test for the fluorescence treponemal antibody absorption test, or FTABs, because of its association to syphilis. Now, we proceed to MembranoPluriphonative Glomeronephritis. Okay? So, what is this? What is this disease all about? Okay, remember guys that MembranoPluriphonative Glomeronephritis is a disease which is marked by two different alterations, okay, in our glomerulus. Particularly, the cellularity of the glomerulus and the cellularity of the peripheral capillaries. Now remember that guys that this cellular proliferation affects the capillary walls and the glomerular basement membrane. Okay? And it is possibly due to immune responses also. Or in other words, immune mediated. Now, take note guys that there are two types for this one. Okay? What are the two types for this one? We have type 1, which displayed increased cellularity in the subendothelial cells of the mesothelium. Okay, and type 2 is extremely dense deposits in the glomerular basement membrane. Now take note people that there is a noticeable progression of chronic glomerulonephritis to nephrotic syndrome. Okay? Again, remember that MembranoPluriphonative Glomeronephritis is marked by two different alterations. Number one is alterations in the cellularity of the glomerulus, Number two is alterations in the cellularity of the peripheral capillaries. Okay? And it has two types. Type 1 is displayed increased cellularity in the subendothelial cells of the mesangium, and type 2 is extremely dense deposits in the glomerular basement membrane. Okay? And type 2 patients may experience chronic glomerulonephritis. Please take note that type 2 patient may develop into uh, chronic glomerulonephritis. Okay. What is this mesangium? That is the interstitial area of the Bowman's capsule. Okay. Type 1 is possible to have a thickening of the capillary walls. Okay. Remember that remember guys that MembranoPluriphonative Glomeronephritis is predominant in children and with poor prognosis. No? It is predominant in children, however, sad to say, there is a poor prognosis. For type 1, it can lead into nephrotic syndrome. For type 2, it can lead into chronic glomerulonephritis. Okay? Laboratory findings includes hematuria, proteinuria, as well as hematuria. Okay? And there is a decrease in serum complement system levels. Okay? So this is what we call membranoproliferative disorder. I will cut the video in this one because it will exceed into 1 hour. Okay, the next discussion will be on the second part.